Grego, one of the medical directors for Baltimore County Fire Department. This is the Baltimore County Fire Department EMS Academy Training Series. I want to welcome tonight Jonah Abraham. I know Dr. Abraham very well. We work together. He is an attending anesthesiologist at Sinai Hospital of Baltimore and the section chief for Pediatric Anesthesiology. He is a graduate of the University of Maryland School of Medicine. He did his anesthesia residency at, what was it, Pittsburgh, right?
That's correct.
And then a fellowship at Peds Anesthesia at Johns Hopkins. He was a member of the Alpha Omega Alpha Honor Society in medicine, which is really cool. And he's an assistant clinical professor of anesthesiology and critical care at the George Washington University School of Medicine. Jonah volunteers in the community with various activities, in addition to working hard at Sinai. The topic tonight's going to be the world's most unfortunate child. And I will let Jonah explain. Welcome, Dr. Abraham.
Thank you very much. And if you have any questions, please feel free to put them into the chat. I may pause it if I get a bunch of questions in the chat to answer them, but feel free to ask away in there as we go along. And thank you for Dr. Sagel. Thank you for inviting me. I'm glad to share some of the stuff that I'm really passionate about. So this is, I just like the title. Mark Twain, Pudd'nhead Wilson's New Calendar. Truth is stranger than fiction, but it's because fiction is obliged to stick to possibilities. Truth is not. And what I'm going to present tonight is a little bit of a mixture of a couple of cases that I've had the privilege to take care of in different circumstances. So this is probably a circumstance that many of you are familiar with. Friday night, 11 o'clock at night, call goes out for a sick child, and you arrive on scene. And you hear the following. So, seems like a chip shot. I think most of you are going to be very familiar. So what is it? I'm going to say it together with me. Laryngotracheitis. All right. Maybe better well known as croup. So what is croup? It's first of all, it's found primarily in children less than 6 years old. But the peak incidence is within 6 months to 3 years. Once you get older than 6 years old, it's less common for that to occur. And I found this to be fascinating. So the time frame in this scenario is classic. It's the croup visits going to the ED is between 10 p.m. and 4 a.m. just when you do not want to be getting a call, but this is very common. So common that 1.3% of all ED visits are because of croup. Which I thought was astounding, but when you reflect on it, it's not that crazy from probably what you experience on a daily basis. Thank you very much for PEDS ED visits. So in studies in the contemporary era, about 5 to 10% of children with croup require hospitalization. So when you're going to bring those children in, they're going to need only a small percentage of them will actually require hospitalization. So what causes croup? Viruses, primarily. The major player is parainfluenza virus, but rhinovirus, RSV, as well as adenoviruses, all of these can cause croup. So what else do many of these viruses cause? Is pretty much the common cold, and it's hard to differentiate that. So why is it different? This is the man flu, dead by dawn, which some of us may experience. So why is it in that 6 months to 3 years, and it really goes away after 6 years old. So we'll review the anatomy for a little bit. This is normal anatomy for trachea. You're going to have thyroid cartilage in the back. You'll have your different tracheal rings and a nice clear trachea. Epiglottis over here, vocal cords over here, esophagus is posterior. What happens when you have croup is that those subglottic tissues, vocal cords again, right over here, those subglottic tissues become inflamed and edematous. So normal, abnormal. And what that does is it changes the airflow. When you are in a healthy patient, breathing in air and out, going back to what these vocal cords are being represented by over here, air is able to flow by nice, laminar, straight flow without any turbulence. When there is some swelling in the glottic area and subglottic area for the pediatric patients, it causes there to be a turbulence. And when they cough, it brings these two tissues much closer together, which causes that barky type of cough. And the reason why you don't have that in adults is that the trachea expands as you grow older, and the radius, when you're going to have a difference in radius, it's actually exponential of how easy it is to breathe with that. So the smaller the trachea, the easier it is for there to be some collapsibility with some edema, with some swelling. And that's why you're only going to find it in children who are smaller. So the important thing to remember about what croup is it's subglottic inflammation. And it's usually has some prodrome to it. There's going to be some nasal discharge and congestion. The kid is once again sick. This is a common cold, a common virus. It just seems to attack the subglottic area a little bit with a greater affinity than other areas. So just like a common cold, you're going to have some nasal discharge and congestion. That's going to occur as well. But you should also have some fever, some hoarseness, and that barking cough, and there may be some stridor. Usually there is minimal, if any, pharyngitis. So you're not going to have much in terms of the sore throat. They're going to be sick, but not so much the sore throat aspect of it. And once again, as that airway narrows, you're going to have stridor and risk of stridor. Going along with that, because they're going to be trying to get past that much smaller airway, you may have a prolonged inspiratory phase along with the given. But they may be starting to work harder and harder, breathing against this in this small airway. So severe respiratory distress can develop. But the fact that it's so rapid, you should start thinking about other etiologies. And croup itself is self-limited. It usually lasts 24 to 72 hours. The cough, which is usually the thing that prompts the calls, and is usually the thing that is scaring parents, and it's usually first-time parents, is that cough will persist. And just letting parents know that this is something to expect, and that it may continue is important as well. But it's the cough is usually the sign of what's going on, and it's more strident to be considered. Complications of croup are uncommon. Things that, you're already sick with a virus. Can you get a bacterial infection? Sure. Can you develop respiratory failure? Sure. But overall, they're uncommon to occur. So when should you be concerned? What are the red flags that you should be looking out for? If it happens suddenly, once again, there should be some history of fever or something going on prior to developing this barking cough. If it happened suddenly, that's when you should be more concerned. And if they're rapidly progressing, if you think that there's airway obstruction for this patient, once again, the acuity is going to be something that's going to be concerning. If this patient's had previous episodes of croup, that's concerning because you want to be wondering why they're having so many episodes of croup, and if there's an underlying abnormality of the upper airway. So, if a patient has baseline comorbidities, particularly to pay attention to neuromuscular disorders, something like cerebral palsy or paraplegia for whatever reason, you may want to consider that that croup is just not going to be croup. They're going to be croup with some severe illness as well. But what if you get confused signals? What if you don't know which way to go? So let's look for the classic signs one more time. The thing to be aware of is that barking cough, that classic finding, subglottic narrowing, and it has a seal-like cough. And I apologize for my humor. I really do. But this is seals dressed up as seals. The other thing that is to be aware of is that they should have a fever. And if they don't have a fever and they haven't been sick with that couple days or at least hours of discomfort, you should start thinking about other possibilities. What are those other possibilities? Spasmodic croup is more like a tic. Some people will especially older children, have a type of tic where they will make that type of sound. And non-infectious causes of croup, such as a subglottic cyst or a subglottic hemangioma, or foreign body aspiration. So when should you really be concerned? If they are having issues swallowing, that's really when my radar goes up. And you want to start thinking about other etiologies and more specifically to think about epiglottitis. If they're having difficulty swallowing and there's a history or the patient's not able to provide that history, you should also keep on your differential a large ingested foreign body. But epiglottitis is something to be concerned of. As we mentioned previously, they shouldn't be having too much in terms of their sore throat. So if they're complaining of a sore throat and they're drooling and they're having trouble swallowing, once again, think about epiglottitis and a pharyngeal abscess. And the reason why I'm kind of focusing on that is patients, children specifically, with epiglottitis, that was drooling was present in 80% of them, while it would be much less common in patients with. So just a couple words about epiglottitis. This is, as a pediatric anesthesiologist, this is when I get I tighten my belt, because this is a true emergency and takes a lot of technical skill at this point. But thankfully, it's much more rare in the area of vaccination. It is primarily caused by H flu type B, but because we were vaccinating against it, it is much less common. And it's the absence of that barking cough that helps differentiate this between croup. The way it's described in the literature is presence of anxiety that's out of proportion to the degree of respiratory distress. Some people already have anxiety that's out of proportion, but these patients are sick quickly. They look terrible. You all have been very much in the field, and you know when a patient is, yeah, they're fine, versus you can take a step back and like, this patient looks terrible. So the patient, the terminology that I like to use is toxic. They really look like they are going to have some type of respiratory and systemic issue. And as mentioned, difficulty swallowing and drooling, and many of them will sit upright. So just like we talked about a normal trachea over here, subglottic inflammation when you have croup. This is epiglottitis. So up in this area over here, up in this area over here. And this really explains why you're going to be having that difficulty swallowing. This is a view looking at the vocal cords using a laryngoscope. And this is a normal epiglottis. You can see the vocal cords very nicely over here, well defined. And this is the exact same view, except with epiglottitis. And this is for a airway expert. This is where it gets very dicey, because you really can't see anything, and at some points you're going to be going in blind, and this tissue is extremely friable. It is inflamed, and you do not get many chances until you lose this airway. So this is a true airway emergency, which needs to be taken care of in the hospital. If you don't have that option, then it's something more so to keep the patient calm than to try to intubate, unless there is no other choice for that patient. So according to our protocols here in Maryland, this is something that is highlighted. If epiglottitis is suspected, one they notice as well drooling with above signs and symptoms, then you should obtain medical consultation, because this is going to be something that is definitely should be managed in the hospital setting. So what about other signs? So more of the regular signs, mild, when you have croup, um, you have to help differentiate between mild, moderate, and severe. Mild and moderate both would be considered priority 2 calls, and severe is going to be priority 1. So the problem is, sometimes you can get lost of like, well, it's barky cough. And is there really a way to help quantify, is this mild, is this moderate, or is this severe? Because based on your definition of mild, moderate, or severe croup, you're going to treat this patient differently. So the best studied score in the literature is this Wesley Croup score. It is something that I use as when I'm riding the ambulance and I see a patient with croup, and it's something that you can find easily online on an app like MedCalc. And what it does is it helps differentiate between that mild, moderate, and severe. Different numbers. If a patient has stridor, it looks at the stridor, it looks at retractions, air entry, saturations, and GCS. And you get different numbers based on different markings. So Wesley Croup score of less than 2 is defined as mild. They may have this cough, they're not strigers, and they may just have some mild chest wall retractions, mild increased work of breathing. Moderate croup, you're going to get a different score, higher score, between 3 to 7. And they're going to have stridor. They're going to have at least mild retractions and some moderate symptoms and signs of respiratory distress. Finally, severe croup is greater than 8. And excuse me, this is going to be significant stridor, significant severe retractions, and other signs of respiratory distress. They may look anxious, agitated, and by the time you meet them, they may already be fatigued. And then finally, if it's a greater than 12, then you should be extremely worried. This is going to be occasionally can occur with impending respiratory failure. So just to give an idea of, croup is not always an emergency. And many pediatricians will feel comfortable getting a phone call at home and treating it with a phone call. But they will sometimes say, call EMS. So what, from the pediatrician's point of view, is their practice guidelines? So if a patient has mild croup, they would recommend Tylenol, encourage fluid intake, and exposure to mist or cold outdoor air. Maybe not the cold outdoor air we've been having over the past couple of days, but when it's a little bit warmer than negative or whatever, then this can help with the patient's symptoms. And I always try to follow the evidence, and the evidence for throwing the kid in the shower with steam seems just to have some benefit to prevent them going to the hospital. It's anecdotal, but it's the risk of anything occurring with that is pretty low. So it seems to be a worthwhile thing for pediatricians to recommend to their patients. But you have to also instruct from the pediatrician's point of view when you should be more concerned. When it's moderate and severe, they should be evaluated in the ED, or they can be evaluated in the office as long as the office is prepared to treat them. But once it's severe, that is an automatic recommendation to go to the ED. So back to our protocols. From a BLS standpoint, when you have croup, you want to ensure the patient has a patent airway, an adequate respiratory effort, and then look for those signs and symptoms going in all those different directions. But nasal flaring, retractions, respirations, skin color, and change in consciousness. All of those are different aspects of the Wesley Croup score. Things that you notice. I just think that the Wesley Croup score helps quantify things that you can make your decision pattern a little bit easier going forward. Oh, we're gonna go back to our story. All right. As Zoe got it correct on our chat. Definitely barky cough. So 3-year-old, you got up the stairs, 3 years old, cough started acutely, but it's a really barky cough, non-toxic appearing, stridor with agitations, mild retractions, and normal oxygen, sat until agitated. So gave this child 1 point for stridor, 1 point for retractions, and 4 points for a decrease in their saturation when they were agitated. So got a total of 6. So BLS units, ask for an ALS unit. I don't know how this is everyone else's experience. All right. So the initial treatment from an ALS standpoint is to, first of all, monitor the cardiac rhythm. And the main reason for that is because you may be giving medications that may cause arrhythmias, specifically epinephrine. Dexamethasone, PO, is recommended for mild, just like they would do for a pediatrician. They would administer that same dose. If it's moderate, then you would also consider adding in nebulized epinephrine. And severe, once again, severe respiratory distress, imminent respiratory arrest, epi IM up to 0.5 milligram IM, as well as dexamethasone IV. And if you can't give IV, then administer it IM, and then also that same dose of epinephrine nebulized. So as recommended, 0.5 milligram per kilo oral. And if you can't do that, or if the patient is severe, then it would be IV or IM. The max dose in our protocols is 10 milligrams. The problem is that it tastes gross, and many children will spit it out, as well as they may vomit just from the administration of dexamethasone. So it's hard sometimes to give them the medication, they throw it up, and you're like, I don't even know how much they ended up getting. I don't know how useful that was. So there are you can, interestingly, you can give the solutions that are given IV, the 4 milligram per milliliter or 10 milligram per milliliter. They are possible that you can give them PO as well. And it seems like it has the same efficacy, whether it's IM or PO. So many times when I'm called to the scene, I end up just giving an IM dose of dexamethasone, because I have found that too many times it's just not worth the trouble and the confusion that ends up going with a PO dose. So how does dexamethasone, or as the trade name is, Decadron, how does it work? So it has 2 great things, which is very useful for what we're trying to do over here. It's an anti-inflammatory. So you've already had an insult with this virus, so it's going to help combat some of the inflammation that the virus stirs up. But more importantly, it decreases that laryngeal mucosal edema. So you go from that more swollen airway to more of that nice laminar straight flow as opposed to the turbulent. So why not just give Decadron to everyone? This seems like it's a great drug, and it doesn't seem like it has much downside. Why not give it to everyone? So the couple of patients to be considerate of are patients who are diabetic. So this dexamethasone will certainly raise their blood glucose levels, and for a significant amount of time. So if they are already fragile diabetics, it's something to be aware of and concerned about. If they are have underlying immunocompromised state, or even worse, if they are going to be considered for a tumor lysis syndrome or something like that, undergoing a cancer treatment, that is something to be aware of. If you're since it is an anti-inflammatory, so it's going to take your entire immune system and bring it down a notch. If a patient was recently exposed or diagnosed with varicella or tuberculosis, it would be something to be considerate of, because they would have, if you're going to decrease the amount that their immune system is able to fight those different diseases, then it may not be worth the benefit. This is, once again, anti-inflammatory, so there's a possibility of the viral infection getting worse or causing a piggyback of a bacterial infection for these patients. And this is something which is not always thought of, which I think can be important to just spend a moment of talking about. We spoke about a hemangioma, so that's an upper airway lesion. If patients have those upper airway lesions, they sometimes can be responsive to a steroid. So this patient has a growth of blood vessels in their trachea, and you can decrease that size of that growth with just Decadron. So it makes the patient feel better. But if this kid keeps on getting croup again and again and again, and they're not so much that they're have a viral illness, they don't have any of those other symptoms, it should alert the provider taking care of them as well as their pediatrician that it may not just be viral related. So we decided that it sounds good. So does it actually work? So in 2018, a Cochrane review, which is the highest level of evidence that is usually available, looked at all these different studies, and it showed that it's really useful giving dexamethasone for group. It reduces symptoms at 2 hours. It shortens the hospital stay, and reduces the rate of visits for patient care. And this is why it's a really good drug as opposed to some of the other steroids that are available. It has a long half-life, 36 to 54 hours. So if a single injection or dose of that medication is going to usually cover the duration of croup. Because remember, croup usually is self-limited about 72 hours. So the first 12 hours, they're not feeling great. They're not, but it's usually that fever, runny nose, etc. Once they start hitting that increased edema in their airway, and they get the dexamethasone, from there forward, you usually have it aligns very nicely for the half-life of dexamethasone in order for the self-limited portion of the disease to go away. Now, let's talk about epinephrine for a minute. So the dose for epinephrine in severe is 0.01 milligrams per kilo, and the nebulized epi is 2.5, and it works quick, within 10 minutes. So exactly how does epi work? So it causes constriction of the and I apologize, we're going to go into a little bit of the details with epi. So it causes constriction of the precapillary arterioles, so the area that is going to supply blood to the areas in the lungs, therefore decreasing how much pressure there is. It also is going to cause whatever fluid is already in the lungs over here, and in those small airways, it's going to allow that to be resorbed, so decrease how much edema there's going to be. And it's also going to cause smooth muscle relaxation and cause the actual small airways, those small bronchi, to dilate. So allow there for to be more, once again, more laminar flow and less issues in terms of edema. Long story short, less swelling, more breathing room in the airways, which is why it's recommended, especially when you get to moderate and severe. So just as the theoretical, you have the 98-year-old pediatrician comes on scene and asks to take over the scene and requests racemic epi. So I pulled some people in the anesthesia world about what is racemic epi, what's the difference between racemic epi and regular epi, and I got a lot of blank stares. So I thought this was worthwhile to go in for a second. This is how racemic epi comes. As you can see, it's only oral inhalation. And just another thing to highlight, the concentration is 2.25%. I'm really sorry. We're going to go into the weeds for just another minute. So it is, when you have epinephrine, it is one side of the molecule. You can have, just like I have two hands, and they're both hands. They're not identical. You can have a left-sided and a right-sided, but they're both hands. Same thing with certain molecules, in this case, epinephrine. When you get that regular epi code dose epi in a vial or in a syringe, that is only one of the hands, only one of the views of that molecule. Racemic epi has both hands, both an L and D enantiomers. So the racemic mixture, you get two different types. So coming out of the weeds a little bit, there's two different molecules of epi, but only one of them actually is active. And racemic epi has significantly higher amount of the active molecule, about 10 times more. And as you can see, there's a difference in how much racemic epi a patient would give, about 10 times more, than the volume of just L-epi, which is the regular epinephrine. Seeing as this is 2.25%, that equals to a lot of epi. But just because you have two different molecules doesn't really make it better. And the thought was, well, two is better than one. It turns out that there's no impact and there's no improvement with patients who receive epinephrine versus racemic epinephrine. So that's why it has kind of gone away, just because it is not as there doesn't seem to be any data to say that that racemic epinephrine is any better. So when you put some people have confused and said, if you put epi into an inhalation administrator, that's racemic epi. Not exactly. Hopefully, you have a little bit more insight into it. But you can use just regular epinephrine for nebulized treatment. So sorry, dude. We're just going to use a regular. So patient feels better. Parents want to stay home. Do you have any concerns for this patient? So the concern is that once you give epinephrine, it only lasts 30 to 60 minutes. Compare this to our dexamethasone that we gave that lasts 36, 54 hours. So the question is, are you going to have this biphasic or rebound effect? And you gave epi, they look so much better. That's great. But once it wears off, can they go back and make things go back to being worse? So when you give epi in general, in my mind, I do not like even considering a refusal. If they were severe enough that they're going to require epinephrine, they should go to the hospital, because the data shows that if they're stable for 3 hours in the ED, that's fine. But none of us are sticking around for 3 hours to make sure that these patients are fine. So if you're giving epi, they should be certainly transported to the hospital. So from the ED perspective, that same 3 hour mark, they can be discharged to home, and it's usually between 3 to 4 hours while they get everything in and after observation. As long as they have no stridor, all of that Wesley Crube score, all of that goes down to 0. No stridor, pulse ox is normal, they sound normal, normal color, their consciousness is normal. And importantly, you're going to have people who are going to be able to watch this child to make sure that if something does occur, they'd be able to get come back to the ED. And then just the knowledge from the ED perspective that 3 to 5% of children that get discharged after getting steroids, and importantly after getting epinephrine, 3 to 5% are going to come back. But those patients were anyways, according to our protocols, the only ones that were going to be getting epinephrine. Patients who have those mild symptoms, the minimal symptoms, it's unlikely for them to come back at all. So when should they go to be admitted to the hospital? Once again, this is going to be rare, but if it's severe coop, poor air entry, if they have a decreased GCS, and you've treated them and they still do not seem to be getting better, especially that terminology again, that toxic appearance, that's something to be considered. If they need oxygen, that's a warning sign for me, because this patient had healthy lungs a couple days ago. Why do they need oxygen now? That warrants a longer hospitalization. Or if they have severe dehydration, simply to treat that in the setting of our man flu or common cold. If they're young, those are going to be smaller airways, so you have to be a little bit more concerned with them. So less than 6 months is something to consider for them to be admitted. And if they were just here, you went to the ED, they rebounded and they're back to you. That's something to be considerate of as well, that they should be admitted, or if they do not have a safe home environment. So when would they need to go to the PICU? If they need to be intubated, I think everyone would understand that admission. But if they are severe symptoms and they keep on getting epi and it's just not improving. Patients that have high risk for progressive respiratory failure. So they're starting out weak. They have some type of neuromuscular disease. They have some underlying bronchopulmonary disease. So they are teetering at the edge just to begin with. So very little will be needed to push them over that precipice. So that warrants admission and observation there. And once again, most of them are not going to need to go to be hospitalized. Very few are going to need to go to the PICU as the way that it is now. So I wanted to just say one slide about Heliox. This is something that we do in the hospital rarely, but the thought behind it can help elucidate kind of what's going on with croup and how we can treat it. So we breathe in. Room air is 21% oxygen, and the rest is nitrogen and Baltimore smog. But we can replace that. When you place a patient on non-rebreather, you're giving them a significantly higher proportion of oxygen versus nitrogen. And when you intubate them, you're giving them 100% oxygen. What Heliox does is it takes out that nitrogen and replaces that nitrogen with helium. And you know, if you've ever experienced or had someone that breathe in a helium balloon, they take a deep breath in and their voice changes. And the reason their voice changes is because the air passing through the vocal cords is not regular air anymore. It's a mixture of helium and oxygen, and it makes that much higher sound. Because it has a lower viscosity, it is much easier to breathe. So it's that turbulence that you saw, the back and forth in an airway that has a lot of edema, that you can either fix the edema or fix what they're breathing in. So by adding in helium, it makes the actual mixture less viscous, less thick in a way, and allows there to be improvement of how they're breathing. And it's not that you're giving them more oxygen, you're just decreasing how much work their muscles have to do. So it just takes the load off of them. So this is just our protocol. So back to our story. 3-year-old, really barky cough, non-toxic appearing, stridor with agitation. So unless you agitate, the only issue is you've been there for a little bit. You gave dexamethasone, you gave epi. It's not proven. So this is where it's like, 1 second, my spidey sense is going off a little bit. Maybe there's something going on. So the patient had a history of asthma. Okay. And the cough started acutely. Also, weird. Once again, if we're dealing with croup, there should be a little bit more of a progressive type of illness. Oh, he was eating peanuts. And has a rash. Anyone want to join the chat? Any concerns? Keep going. My spidey sense is going on.
Yeah, let's see.
Did I give it away? I'm sorry. Very good. Thank you, Matt. So yeah, now I'm like, oh, is it an allergic reaction? And to think about anaphylaxis. So anaphylaxis is a systemic reaction involving multiple organ systems. It's usually that there's some type of exposure to an allergen. And we're going to go back into a little bit into these mast cells and basophils. But what it does is it releases a ton of badness into the body that affects a lot of things. So we look for if there's severe illness after exposure to a suspected allergen. And we have 2 of these criteria: hives or swelling of the mucosa, which we kind of have over here, some respiratory compromise, hypotension, or GI symptoms. So back to our story. So you have to be really concerned, because the thing with anaphylaxis is this is very time dependent. There are some things that you can rest on your laurels. When there is an allergic reaction, outcomes are shown that when you treat patients earlier, then they will survive and they will have better outcomes from it. And it can happen within minutes. So if you are hemming and hawing, am I going to treat this? Am I not going to treat this? You losing precious time, because it really appears that when you treat earlier, they do better. When you treat later, those are, even though they've gotten the treatments, which we'll go into shortly, they have worse outcomes. And really the cornerstones of the initial management are, if you can remove the inciting cause, stop the medication, take the bee sting out of the venom out of the patient, then great. Placing the patient in a supine position, lower extremities elevated, is also definitely recommended. But if they're vomiting or if they're pregnant, have them on their left side, have them lean over so they don't have a aspiration. So what if there's no rash? Are you still concerned? So 10 to 20% of patients with true anaphylaxis will not have any skin findings. And back to our red flags. Once again, a lot of things that you're familiar with. Rapid progression of symptoms, evidence of respiratory distress, poor perfusion, abdominal pain, vomiting, or dysrhythmias, and finally hypertension. I love this because we have patients every once in a while that say, no, they're allergic to epinephrine. I have to say 99 out of 100 times, what happens is that we're having a dental procedure. The dentist puts some lidocaine numbing medication together with epinephrine, and their reaction to epinephrine is their heart races. So I wouldn't say that that's an allergy to epinephrine, because that's pretty much what we got for an allergic reaction and anaphylaxis. But there actually is some evidence that some hypersensitivity. So there can be some people who have a hypersensitivity to epinephrine. It may be from the other thing that it's combined with in order to make the epinephrine. But it is still possible. I'm not going to throw it out completely, but it doesn't change what we're going to do because there are some people who are like, well, maybe we shouldn't give epi in certain locations. Patients with coronary artery disease, their heart is already kind of weak, is concerning that you may stress it too much. But that same heart, which you're worried about it being stressed, this is exactly where the mast cells are releasing the histamine, and it causes there to be increased stress from that standpoint. So there's greater risk by not treating it than by treating it. And if you it may mask when you don't treat anaphylaxis, this extreme hypotension can also cause coronary artery disease to kind of reveal its nasty face. So it is, even though there are patients who have a history of coronary artery disease, you should be careful and watch for issues associated with that coronary artery disease. But it is definitely not contraindicated to give epinephrine. Other patients to think about if they are on certain medications like TCAs or MIOs, MOIs, or if they have diseases like an aortic aneurysm that you really don't want to raise your blood pressure too much and burst that aneurysm. But if you're left with treating anaphylaxis versus having to deal with your aneurysm, you may not, it's a rock and a hard place. But sometimes you have to do what you have to do. Also, patients who are on stimulant medications, treatments like Adderall for ADHD, they are already, their sympathetic system is already ramped up. So it should be given with caution, but still should be given. So what about, I've already thrown in an IV. Do I just push epi IV for this patient? And it seems like in the data in the literature that it's not recommended. still give it IM, even if you do have an IV. One of the reasons is because sometimes it's going to take longer and you're going to be fumbling with the IV, even if you're really good, that with administration of the IV dose. And it actually gives a great plasma and tissue concentration with epinephrine. So it's not really beneficial. Plus, that same way that we were concerned about coronary artery disease for these patients because you're giving epi, it seems to have less risk of severe hypertension, less risk of ventricular arrhythmias because you're giving it. It gets up there quick, but it doesn't get to the level where it's going to be causing that level of side effects and complications. So this is also reflected in our protocol. Epinephrine should never be given by IV route except by an infusion. Similar to that, when you give it IM, it's going to be getting a good plasma concentration. When you give it as an infusion, you're not going to be stressing all the body symptoms as versus a bolus dose. And this was something that I thought was very interesting. So this a case study of 164 fatalities due to anaphylaxis. It really depends on what was the inciting event. So if it's iatrogenic, meaning you gave something, let's say contrast dye, in the hospital, so something that was given by someone else, not food related, usually medication related, that happens quick. That's 5 minutes. If it's a stinging insect, 15 minutes. And probably the most common that we see, more so than in Maryland, some of the stinging insects happen elsewhere a little bit more often, but we usually see food-induced anaphylaxis. So there, thankfully, you have a little bit more time, 30 minutes for that. And there's a difference between food and venom and medication induced anaphylaxis because food, it's usually difficulty breathing, as opposed to the other two, it's usually cardiovascular collapse. That's usually why these patients dies. And kind of unfortunate for our patient over here, asthma is a significant risk factor for fatal anaphylaxis, especially with patients with a food allergy. But because that cardiovascular collapse is more common with these other things, with the other venom or medication induced. When they're older, it's usually also cardiopulmonary conditions that's causing them to die. So why does fatal anaphylaxis occur? It's usually because you didn't give it right away. So the other thing is something we're going to talk about in a moment, something called empty ventricle syndrome. And when they're the way that they diagnosed fatal anaphylaxis is usually based on the story and what happened during that story. They can check the venous blood after the patient has passed and do for tryptase, which usually is a sign that there was an allergic reaction, but they may not find anything on autopsy. And I just wanted to talk about this empty ventricle syndrome because if you don't have an issue with the airway, if we're concerned about the airway being too edematous and the patient's respiratory effort is okay, you should really have them lay down, raise their lower extremities, because you can have something called empty ventricle system. You have all the blood in your body when the patient's sitting bolt upright, suddenly gets released, and it's all gets pooled into their lower extremities, and the blood, the venous system is not able to return that blood back to the heart. And interestingly, this it seems is what kills a lot of patients within seconds because they have anaphylaxis, they cause severe hypotension, but the collapse is more so from the blood not going back to the heart and an empty ventricle. So I've never tried to do CPR on a patient sitting upright, but if a patient is many times we end up going supine anyways, but this would be even more so a reason to get the patient in the recumbent position, and patients on the left lateral if they are pregnant. Really, it's a miracle drug. It fixes all of the things. It stops those mast cells from sending out these evil humors of histamine. It stops the obstruction of the airways. It really reduces how much edema it is, and just like in a code situation, it can help reverse cardiovascular collapse. So it really is the mainstay for anaphylaxis. What about other drugs? They are in our protocol, but they are kind of like chicken soup. Um, they it makes the patient feel better, but it's not going to affect the clinical course for this patient. Diphenhydramine, Benadryl can relieve the itch, can relieve the hives. Albuterol can help them breathe a little bit better, but it's not going to be as good as epi. But it's not going to hurt those patients in the vast majority. And steroids, it's going to maybe this is an allergic reaction. This can decrease the inflammation going on, but it's also not going to make a patient actually do better in the long term. So really, the main thing is if a patient is hypotensive, treat it. Treat it with fluids. Treat it with that, as outlined in our protocols. So, cough started acutely. It looks terrible. He was eating peanuts. True story. So, he had an episode of choking. Someone astutely starts listening to the patient and notices that there are breath sounds. I'm sorry, are just on the left. There are decreased breath sounds on the right. Chat people. Anyone want to give a guess what's going on now? Thank you. Yeah, this is very concerning. Took an X-ray as the patient had worsening respiratory status, but it was still non-emergent. So this is a foreign body aspiration. This child, the thing that they were allergic to, unfortunately, they didn't even swallow in their esophagus. They swallowed in their trachea. They aspirated it in their trachea, which is why this patient had acute barking cough, had acute laryngeal edema. So it had that same edema because those localized tissues were now scrunched and closed and not doing well. In the hospital setting, you may see, and if they got a chest X-ray, you may see hyperinflation of that of the lung that is affected because all of this air is trapped. It's not going in and out, as opposed to this side, which is normal. So our child aspirated a foreign body, peanut. And now we're at the hospital. Yay. But patient's now having greater respiratory effort. You want to try getting it out in the field? So you can. But this is what our protocol says. So if in infants and young children, when you have stridor, call ALS and start moving because the patient can decompensate quickly. And you should have tools that are you're going to be able to manipulate the patient's airway. There are two things that that are useful for foreign body aspiration if you're trying to retrieve a foreign body. In the top right is a McGill's forceps. It's very useful to pluck something out of the airway or the esophagus. And bottom left is direct laryngoscopy. I didn't include any slides about this, but video laryngoscopy, something like a glide scope, has been shown to be much more successful, much quicker, and first pass attempt is going to be more successful. The problem with it, and the reason why I encourage my trainees to still learn how to do direct laryngoscopy is there's sometimes that using a glide scope or a video laryngoscope is not going to be what you need to do. So this happens to be one of them, because you usually are not going to be able to manipulate the airway as well with McGill forceps if you're using video laryngoscopy as opposed to using direct laryngoscopy. So it's something that if it's straight airway issues, then I would recommend using video laryngoscopy if it's available to you, but never let those tools rust because you really you never know when you're going to need to actually do a direct laryngoscopy in order to retrieve something from the airway. And it's far easier to do so when you do it direct laryngoscopy. I can't see anyone, but I'm assuming everyone's going to shake their head no over here. So children under the age of 8 should not receive a surgical cricothyroidotomy. they may receive only a needle tricotherapy. And the reason is because these patients' airways are much smaller. You're not going to be able to get through the tracheal rings, and the anatomy gets distorted very quickly. So this is not a good idea. So we brought this patient to the OR. We established the peripheral IV, and we gave medications that would keep the patient anesthetized, but still spontaneously ventilate. And then this is the view we got of the vocal cords, which is normal. So the ENT went in and did something called a rigid bronchoscopy, which is with the patient ventilating, they would go down with that long tube that they're holding it in their right hand, and you're able to go down through the mouth into the trachea and be able to retrieve things. And lo and behold, there was a peanut down there. So they did the bronchoscopy, but this was the issue. This was honestly terrifying. Every time they tried to pull that peanut out, they lost CO2. And the reason was because every time they tried to get it and they got it just to the vocal cords, it caused complete airway obstruction. So what we did is push the peanut back in, which sounds kind of counterintuitive, but you end up doing one lung ventilation. So it ended up most of the time on the right lung. So the right main stem bronchus. And we're still able to ventilate the left lung. So it worked, but this patient can't stay with this allergen in their trachea with having one lung ventilation. So the plan was to do an open tracheostomy in the operating room in order to retrieve this peanut. What if that fails? And this was something that we actually had to prep for because we unfortunately were struggling to get this peanut out, and it was not coming. And if it was not going to be able to fit through the trachea initially, and if we lost end-tidal CO2, if we lost the ability to ventilate again, this patient would expire. So there was an alternative that we actually brought up. Cut the peanut in half. That would be interesting, except now you have two peanuts. And if one of them ends up further in the airway and you can't retrieve it, that might make things worse. But you have to make sure that none of it's going to go further in the airway, because if it would be further in the airway, then you're just going to have an allergen, and this patient can have continuous anaphylactic reaction and have a granuloma in their lung for long term. So that was a thought, but it's not. It didn't seem like the best thing to do. So something that we prepped for was VV ECMO, and you could do this in the youngest of children, but in adults as well. VV ECMO is venous ECMO, and it's a form of life support. It can be used temporarily to support patients who have acute respiratory failure. And one of the V are central vein, and the other V is into a different vein. So there are two different types of ECMO. We were considering VV ECMO, and the reason is we wanted just to make sure that this patient got enough oxygen. So even if their lungs were completely obstructed, we could pull blood from their vein, usually a lower extremity ephemeral vein, pull that blood out, circulate it through with our pump, oxygenate it extracorporeally, so out of the body, and then put that oxygenated blood back in through their vein, which is you can have patients who have severe respiratory issues, just like our patient over here, who had a severe respiratory issue. Their lungs weren't working, and they don't even have to work at all if you hook them to this. You could have them have their blood go through here, and they are going to be oxygenated through the machine. There's another type of ECMO which is used when the patient's heart is not good. So this is called VA ECMO, where they'll be pulling blood from the vein, oxygenating it as well, but this time they're going to actually be using the apparatus outside of the body to help pump the blood. This is a lot more invasive. This has a lot worse outcomes, but it's when a patient's heart is not working well. So that is VA ECMO, but we were actually hooking our patient up to VV ECMO just in case the patient needed to had a complete airway obstruction, and we would not be able to ventilate it. We did it. We got the whole peanut out, which is great. But that wasn't the end of the story, unfortunately, for this patient. The pulse ox starts going down after we've done a tracheostomy, after we got the peanut down, and now our saturations stink. They were fine beforehand, but now we're in the low 80s. Even though, you know, the surgeons at this point are congratulating themselves for getting it out, the anesthesiologist is sweating away because what is going on with this patient? Why are their saturations low? So there were a couple of things that could happen. A pneumothorax could have occurred, but we thankfully had a chest X-ray in the operating room, and there were impressive crackles when we listened to this patient, and we were able to get a chest X-ray after their tracheostomy. So I think if I showed you this picture and I told you crackles with hypoxemia in an adult patient, I think the vast majority of us would think of pulmonary edema, maybe congestive heart failure or something like that. This is kinda, but it's a different entity, and one that I thought would be interesting for you all to be aware of as well. This is something called negative pressure pulmonary edema, and it's when a patient tries to take a deep breath in against a closed glottis, kind of like in our case. The patient was breathing spontaneously, but that peanut obstructed their view, and when they take a deep breath in, this can develop negative pressure pulmonary edema. So just to speak out what these words say, when you try to flatten this diaphragm, you have the two, as an analogy, you have your two balloons, which are your two lungs. So when you try to you pull down your diaphragm, those two balloons get sucked in really, really tight. And since there's no air going in, they just get really collapsed all the way down. And what that does is it drives all the fluid that was in the lungs now from those lungs into the actual airways. And it draws out fluid that was surrounding the lungs as well, now into the lungs. So what you do is something called flash pulmonary edema, or in this case, negative pressure, because you are trying to take a deep breath in. That's the negative pressure, and it causes immediate pulmonary edema. We do see this in the operating room or in the PACU setting, in the post-anesthesia care unit, not uncommonly. And it is, but it doesn't always happen right away. It can happen up to 12 hours after leaving an upper airway obstruction. Patients who are already at baseline, once again, it's something to be concerned about for obstruction. For example, they're obese or have obstructive sleep apnea, they have the greatest risk. But the other cohort that seems to have this risk are young, healthy, athletic adults that had a breathing tube in at some point and then took a deep breath or bit down on their breathing tube while trying to take a deep breath in, and it can cause this flash pulmonary edema as well. So this is the end of the lecture. Once again, drawing off of my experiences, it's crazy that some of these things can happen, but as you experience every single day, sometimes truth is stranger than fiction. So first of all, I wanted to say thank you to all of you for doing what you do every day to keep us safe and to keep everyone rocking and rolling, and I'm happy to take any questions.
So Jonah, you've touched on at the start of this, two of the most scary moments I've had in my career. The first one was a small kid with epiglottitis, and I was an anesthesia resident. And it's like very high pucker factor, as they say. And that kid ended up getting an emergency trach. But ever since the muffler influenza vaccine has come out, we don't see it anymore. Thank goodness, because they were true emergencies. And there's nothing worse than seeing a Smurf in the operating room. The second one was a foreign body aspiration, and by some miracle, I was able to pull it out of the trachea. Again, a kid with McGill's. But yeah, this is scary stuff, but it's real.
Yeah.
So,
So, Amber, good question. Diuretics, not so much. But you can use PEEP. The reason is because, and I like to think about this in general from like that young, healthy, because this is where I've seen it the most common in our PACUs. They were young, healthy lungs beforehand, and they're going to return to be young, healthy lungs. It's just there was one tidal wave of pulmonary edema that hit those lungs, and it's going to take a little bit of time for that to come out. So diuretics usually do not have a place in treatment of pulmonary edema. PEEP, CPAP, BiPAP would help, but it's going to be a temporizing measure. Usually these patients do not require reintubation, do not require long-term PEEP or CPAP, but it is PEEP. Yes, you are correct. PEEP would be indicated for those patients. Thank you for the question.
Hi, this was a great talk. I have a question for you. Can you hear me?
Yep.
Excellent. I've had on 2 occasions pediatric patients that had significant vasovagal episodes following blood draws. So to the extent where it is profound, extended, they look, to use your term, toxic, is there a role for epi in that type of environment? Is it similar, or is it a pseudo-anaphylactic episode at some point?
So it's funny. I had a patient. We were transporting them from their home to the hospital about 4 hours ago, and I had a lot of some new EMTs and some wizened paramedics, and it was myself. And the patient had a vasovagal episode at home with some blood loss. They were post-op, but it was clearly a vasovagal episode. And then we could see we were placing an IV, just as you were saying, in the ambulance. And she was saying, I don't feel good. I feel like I'm going to pass out. And I directed everyone's attention to the monitor to watch that patient go to not asystole, but I wanted a little bit more beeps per screen. And I asked them to run the blood pressure more often. If you are certain that is vasovagal, then epinephrine is not going to be worthwhile. And because the issue is that you have a surge of a parasympathetic activity. So, and by the time you get epi in, you need it to circulate. And the way that it's going to circulate is either that heart gets moving again, or you're going to start doing chest compression. So if you're so concerned that the patient went into sustained asystole from a vasovagal episode, then chest compressions and transcutaneous pacing may be even more warranted if they do at least have a heart rate. Otherwise, you're in a regular code situation. So it's usually not something that I would treat with epinephrine. It's usually time. Take a deep breath. Could tell everyone around you this is going to get better. But it's not always easy to make that call. So drawing up epi won't hurt. But I think by the time that you'd be ready to administer it, the vast majority of these patients have an increase in their heart rate and are starting the road to recovery.
And so, quick follow-up: is there a role for atropine in those patients?
That would be the more appropriate drug. But once again, I think that if you are, by the time that you're ready to administer it, these are usually transient. And if it's not transient, there may be some underlying cardiac issue. But for pediatric patients, atropine, I would be a little bit more quick to give, but also unlikely that you're going to be able to treat it by the time that it's actually going to be clinically relevant. So the answer to your question is you could, but it's usually not going to happen.
Great talk. Thanks.
Thank you.
I'll remind everyone again that if you would like some continuing ed, go to the chat, click the link. Please enter your information complete and accurate as it is listed with NIMS so you can get credit. Thank you very much, Jonah.
My pleasure.
I was paying attention to no PEDS calls so far because
That's right. Thankfully.
a little nervous for a little bit.
Well, I'm in-house, so if there was something that would have happened, I would have just had you finish the lecture. You could have done it. May not have gotten all the jokes, but
Oh my, it's all good. Does anyone have any other questions? Let's see, we got a bunch of stuff in the chat. I don't know, have you read it?